I'd like to now introduce Aloha Sison, who's a nurse practitioner who aspires to provide pivotal work across various settings in providing excellent, compassionate care to older people from New Zealand. And Sison's a nurse practitioner and has over a decade of experience, but she really has started to focus in on supporting the Whatu Ora. I hope I said that correctly, but going to give us the insight into your experience there. Thanks. Aloha.
So yeah, hi, good afternoon. Yeah, it's 5:30 actually here in New Zealand, and it's winter and it's cold. So yeah, again, thank you for the introduction. My name's Aloha Sison. I'm a nurse practitioner currently working under the nurse-led services at Te Whatu Ora Waikato, and also doing part-time role as primary care provider and providing services to rest homes. So in my role, though, as a nurse practitioner in Te Whatu Ora Waikato, I have led multiple projects to support our aged residential care facilities in the Waikato region. So we've got 63 facilities here. And one of the work that I've been really proud of is the virtual registered nurse service, which was developed alongside previously it was called the Health for Older People strategy and funding in our nursing directorate. But it is a service that we provided out of COVID. Actually was an 18-month pilot. So yeah, so just I guess I want to also thank Victoria for inviting me, because I'm also representing the College of Gerontology in New Zealand. So I'll start so I had to look at what's the concept of pulling a rabbit out of a hat. So having an unorthodox solution, doing something unexpected or surprising, solving problems with out of nowhere really. And I think it's very much an apt metaphor for how we might want to think about the future of our older adult care. And it is where we embrace that bold but unorthodox mindset and to reimagine our service care delivery. But always, I think, listening to Noel as well, always our core value is that we want to care. So this service was developed because of our care, not just for our older adults, but at that time when we were in so much pressure, it was also the care for our workforce. And it is really that being able to support them within their locality and continue to be able to work in that area, in that setting. So this is the virtual we called it VRN service. And what led to that service creation? So actually, in a nutshell, it's a service that we've got we've got 10 aged residential care facilities in rural areas, about 10 residential care facilities, and we've got RNs located in the hospital here in Hamilton, which is it's in the city. So, but they are getting help through that VRN with a team lead caregiver within the facility. So how it started really, because this is not a traditional method of delivery of care for our registered nurses. So during COVID, so once upon a time when COVID happened, we were impacted. There was so much impact because of staffing shortage, and it has been felt across the region. Facilities were experiencing workforce burnout, contributing to poor staff retention. They were experiencing high clinical risk. And I must just add, with the workforce burnout, some of our facility managers were camping outside the facilities just to meet that requirement of having a registered nurse on site. We already know, and this is not probably an uncommon story to hear, that RNs, clinical managers, were on call for 7 days, for 14 days, and then having to work 16 hours or even 24 hours. during that time. So there was also, we cannot facilitate any acute bed movement at that time. And then the biggest impact is that our older adults were having to be moved to cities, or an hour or 2 hours away from their family, because we cannot support them to be placed locally. So that was also a big trigger for us to make sure that to try really push for this service to happen. So initiative to support the workforce, to help those 10 independent, and out of those 63 facilities, we've only targeted our rural facilities that are trust and independent. They're not trust or private owned facilities. So and these were, in terms of having it measurable, we had a reporting system here in New Zealand. They submit Section 31s because facilities weren't meeting or were at breach of the residential care agreement, not having a registered nurse on site. But these are the risks that we were dealing with at that time. This is the map, and Waikato population, this is just general population, would be just under 500,000. And then we've got the area, 59% urban and 41% rural. So if you look at the red dots, this would be the facilities that we had supported through the VRN service. And so if I would just want to, like, when Noel was talking, I was like, oh, this is how I actually envisioned it. Having like a triangle where you've got all the RNs, our coordinators being able to refer to a nurse specialist, and then a nurse practitioner and a senior medical officer, or in Noel's case, a specialist, a psychiatrist, a mental health expert. So that's how, because we are also quite spread. My furthest facility or area of cover would be probably 2.5 hours. So it's if you look at your 8-hour workday, 5 hours would be spent traveling to and from. So that's the challenge of having a big area. So this is this is that. And then I'll just quickly go through the project flow. So with I think the challenge is that, number one, like I did mention earlier, it's not a traditional way of providing RN care, and that what a lot of stakeholders were really questioning. Is it safe for the RNs who are supporting, delegating tasks to our team lead HAs? And I know that would be maybe for my colleagues one of the questions as well. So in terms of the designing, we brought in the facility and clinical managers to have that opportunity to say, we're faced with this big problem. How do we try and solve, and what are our risks, and how do we mitigate the risk? And what are our key performance indicators? So our key performance indicators, and this is only done in a very short period, we identified, number one is the supporting the older adult, making them the center of the project. So we don't want them to be living away from their family, particularly if they're already on their last days of life. They've got, the family would be traveling 2 hours, and then sometimes that would be a big barrier for them. Looking after the staff, and also supporting the health system at the time where we are able to support reduce hospital stay, and then also support the facilities in accepting timely discharge. In doing the risk identification, we've identified that during those night shifts, the common incidents were falls, or the high risk incidents would be having someone deteriorate overnight. And how do we manage this? So based on that, we were able to consult subject matter expert, like and I'll just quickly run through it. So you've got the falls. I created post-fall assessment that of the virtual RN and the team lead caregiver can use, so that you've got the person, you've got the registered nurse using with their device, able to guide the caregiver as they go through the physical assessment. And also they've got tools like the stop and watch tool to have this deterioration detection. And through that risk identification, I was able to deliver an education study day to the identified team lead HAs face-to-face in the facility. Because then I think it's very important that the caregivers are able to speak the language of the nurses and vice versa. So that, and of course, when you're having this virtual RN service at night, then we want to eliminate that worry of the caregivers that they would be waking up someone in the middle of the night. So we created it, or we designed it in a way where it is a proactive service. So the facilities will have 16 hours of RN time, which is the morning and afternoon shift. They hand over to the virtual registered nurse, who will be, so that's the first interaction between the team lead HCA, the afternoon RN, and our VRN nurse. And then they would have a proactive call, which is around after their first rounds. And that would be the RN initiating the call and not the caregiver having to ring and worry, oh, am I waking up the RN? And then the second one would be around after their second rounds, wet rounds. So, they change their nappies and whatnot. And then the next one would be the morning handover, where it would be received by their morning RN. So and then project implementation. So we use the Microsoft Teams, and I know, these facilities were already using Medimap, or they already had a system in place in terms of IT. So we use Microsoft Teams. It's also secure in terms of confidentiality. We've got a waiver in place for them in terms of that audit, but it had mandatory requirements. So it included the competency and qualification of the team lead HAs, which at that time actually we had a lot of IQNs who were waiting for their CAP course, and then they had to be level 4, or they had to be medication competent, first aid trained, able to. So they had a lot of training prior to us commencing. We had a system where in the Microsoft Teams, all the organizational policies were in there. And then we also had an escalation point where, yes, we have the VRN, they do have a team lead HCA, but that doesn't replace the on-call clinical manager or on-call facility manager. So in that case, if there's any issues that needs oversight or that needs attendance on site by the RNs, then they still have the ability. But later on, I'll show you how much difference it made to the lives of these clinical managers and facility managers through the service. Also, in terms of the project monitoring and controlling, initially we had weekly catch up with our facilities. And so that meant that we were able to discuss, are we having issues? Are we having any complaints? So actually, that in a result of that weekly catch up, weekly meeting, was that one of the main thing that they had overnight was opioid administration. So because initially we said no, because too much high risk for our caregivers, but through that we were able to liaise with subject matter experts, palliative team, and we were able to create a guideline that is safe in consultation with the VRNs, safe for the facility and safe for the resident. So if I just the opioid, they were allowed to give PRN with a virtual service online, and then at the same time they would have, it won't be the residents' first time having that opioid, and then so there's some strict guidelines around it, like having the sedation score, and that's all delegated by the virtual RN. So yes, and so this is just the model. So if you look at it, we've got more than 10 facilities. They provide direct care to the resident. They've got the team lead HAs or enrolled nurses, and then they are looked after by VRNs. So the ideal ratio at that time was one VRN is to 5 facilities, because we didn't want to overload them, and then we still have that oversight from the facility and clinical manager. So successes. I hope I don't forget any of our success stories, but yes, so this is, the family, friends, they're able to visit their family members, clinical safety, ARC workforce, the health system, residents, patients. So that ARC workforce support and relief, reduced level of stress. Initially, when we did our survey, they had the stress level of the facility managers, clinical managers were between 9 to 10. After the commencement, it's all gone down to less than 5. The calls that they were getting prior to the service, they were getting called every night, because even caregivers having, they needed support. Also, they had a few IQ and international qualified nurses, so they were the direct, first port of contact. While with the VRN service, they are able to have at least good rest. In the survey, it did show that in 6 months they only called in once or twice, so that was a significant drop of the phone calls that they were getting. In terms of the clinical safety, we didn't have any sentinel events, no complaints from the family during that 18-month period. Operational delays, I don't know if you use Interai or like what assessment you use, but during that time, they were more than 50% overdue, because the facility managers and clinical managers are now having good rest. They are able to function during the day better. And so they were able to catch up with these operational requirements. And then we were able to support end-of-life patients, even with the pumps, to go back to their locality, because there is that service. And then that workforce support, facility managers were able to give annual leave to the staff members who hasn't gone home for more than a year or hasn't had annual leave for that lengthened period because of the workforce shortage. Yeah, so the reporting period is between August 9, 2022 to June 30, 2024. And then with a reported 20,000 interactions between VRNs and their partner facilities. So yeah, total of 656 days with an average of 30 interactions per overnight shift. So this is just, and they would have different sort of level, because some of them started a bit late in the service, so like 2 or 3 months after we've commenced. So call mode, this is the result for our second survey, but the first survey was really more than 50% for the video. And I think as they grow more familiar with the staff, they develop that trust. They're using more of that chat, and then it's more of update, because it's become so not routinary, but they're really, I think the beauty of it as well is that the afternoon RNs preempt what potentially the issues is, and even the morning RNs think, oh, we don't want them to deteriorate overnight, because I know my colleague will be, the team lead HA will really struggle or will have to deal with hospital transfers and whatnot. So I think that has also not just strengthened the relationship between the Whatu Ora, the DHB, the District Health Board, and the private providers, but also internally they've strengthened that relationship. Reason for call, as you say, it's very consistent with our service model, where you've got those RN check-ins and handovers are the highest reason for call. And so this would also in some ways tell you there's not a lot of incidents during the night. So this is like the reason for call. You'd say 44.89%. It's really pain relief, and mostly it's Panadol. That extra dose of Panadol overnight that the residents are asking for. There would be a lot of medication and not a lot of falls or that deteriorating resident, because I can show you how much we've transferred as well later on via ambulance. This is so out of, if you look at these different facilities, out of 1,300 calls, they've got 10 transfers, and that's in 18 spread out in almost 18 months. And that would indicate, I think it's less than 1% for hospital transfers. And we've followed hospital transfers. They're all appropriate hospital transfers. So that means that if a facility, if a team lead HA escalates an issue, it's responded appropriately by the VRN. If they wish to call the GP, they can. They can also escalate to the they can also escalate to the clinical manager, but in general, they are able to facilitate transfer. The caregivers are trained to prepare all the documentation to transfer with the patient. Facility RN code, and like I say, this is 26 out of 1,300 on the first one. If you look at the I won't go individually, but again, that's gonna be less than 1% of times where the facility RN had to go in the facility to support them. GP called, and this is also one thing. Initially, we had phone calls from GPs concerned about, is this gonna increase our calls? But actually it did not. It was all appropriate calls. Maybe the odd times where they had to I can't remember an incident actually where they have been phoned that I know of, but it's very rare. Generally, the RNs would also go through the clinical managers before the GPs were called. So that's not an increase as well. Yeah, so I hope I've discussed the results. But yeah, so learnings, I think there's still space, or there's still always opportunity to learn. I know for a fact that we're not the first one to implement this kind of service in the world, because globally there's a lot of telehealth services that are in place. And we also, before commencing it, we've drawn and looked at what they've done, what could potentially fail. And like I say, we don't want to put these facilities at risk and our VRNs at risk. But certainly this is the way forward. And it's only a pilot service, and it has ended, but there is, it's not necessary. I suppose what we're looking at is taking it to a bigger region, and not just limiting it to team lead HAs, because in New Zealand, a lot of our aged care facilities have internationally qualified nurse. And as an IQN myself, it is that first few years is very tricky working in isolation. It's good to have someone that you can bounce back ideas with. And I put the Olympics ring because I thought, well, as nurses, we've got the grit and perseverance and resilience to build something or pull something out of nowhere. And I think certainly this was a service that was set up very quickly because we had to respond to a problem. But I think that also opened, the results of the number of incidents overnight open up, we can potentially do this. Because then I think the older adults in creating our delivery of care, we don't just want them to survive, we want them to thrive and then hopefully flourish in their locality, that's their land. And so I'll just take this opportunity to also invite you to our conference next year in New Zealand. And this is our theme, surfing the waves of aging. So yeah, that's in May.
Thanks very much, Aloha. That's fabulous presentation, and what a great service, but also what a great lot of data you've really collected about it. And I think the way you went about setting that up so that it was clearly safe has been fantastic. And I know, as you say, during COVID, people became quite nimble and innovative, and some things like that were happening in Australia, but it was rather sad to see how quickly it got wound back because it was like, oh, well, we have to revert to our old way of working. But I do think now people are revisiting that and starting to call for a lot more of this virtual support and input. So well done. And that's very interesting quality project. So there are a few questions here. Lily O'Donoghue Jenkins has said, I'm really interested in your VRN service, and so she's got quite a few questions here and really about the operational aspects of it. But for the first ones, how did VRNs access patients' medical records? And, was that through a digital platform? Mm-hmm. And were there any barriers with the Wi-Fi connectivity?
Yeah, so fortunately, I think 9 out of 10 of our facilities had an electronic documentation system. And I have emphasized the importance of having escalation points as well, because I think with technology, with the advancement of technology, we cannot, like humans, I suppose, sometimes they're very unpredictable. And so we had that backup plan. If the system's down, we've got mobile phones. And if not, then we are able to reach out to our facility managers and clinical managers who are still within that 10-kilometer radius in that facility as well.
Yep, lovely. And were there, what governance mechanisms did you establish? Oh, well, you've got escalation protocols, supervision and designation of tasks. I guess that's quite an interesting aspect of this as well, the sort of governance around the designation of tasks.
Task in terms of the RN task?
Well, as you were sort of supervising people to assess, you mentioned that you had that sort of element of you had assessments and
I developed a study day as well as to if there's any assessment required. Like one of the things that they were really concerned was that if a patient was deteriorating overnight, so using tools, I suppose like SBAR, and then really empowering would be the right term, our team lead HAs to be able to use these tools so that they can speak to the RNs clearly, but then also in terms of that when they get to the recommendation. And I always tell them, if you are not happy with the response of the VRN, then you ask questions like, for my own, you teach them how to communicate for my own learning. How are you able to explain why this is your approach or the intervention that we provide now? Because sometimes I said, sometimes we paint a picture and it's not just, we're all trained differently, from a nurse to doctor to caregiver. Sometimes we don't paint the picture that we want to paint clearly. And so that's where the problem is this. Sometimes as a person on the floor, you see the sense of urgency, but someone receiving that phone call might say, oh, we can just watch and see. So then if they're not happy with that response, it's being able to ask back, why? I think it's that critical thinking and always asking the question, why are we doing what we're doing?
Yep, fantastic. And obviously it was working well. And it's so exciting to think of the number of people who didn't suffer in pain overnight or didn't suffer an unnecessary transfer because of this service. So I've got Marion Cummings has said, great project. The RN's way of the future. I agree, especially remote areas. I hope some Australian areas take it on. They're asking, have you published this somewhere?
You're the first to hear.
Oh, fantastic.
I've shared those results, but then I'll also send it to the Ministry of Health, because the funding, so there's a funding aspect to it. The Ministry of Health funded the project.
Yes, so okay.
So it was free of charge for the facilities.
Well, fantastic. Well, definitely you should be publishing that and be very interested in Australia. I know it's under consideration, this type of intervention. So Leah McAdam has said, excellent initiative, Aloha. Co-design, which I did hear as well, that you very much was around co-design and patient public involvement. Is increasingly used in Scotland, UK. This might be a good strategy, close to rural communities. To foster a sense of ownership in service development. Is this something that's been explored with rural communities in Australia and New Zealand? The co-design element. I mean, I know in Australia, rural health often tackle things in a bit of a co-design way. I'm not quite sure how far it's gone into aged care services.
Yeah. Oh, that was really, a workshop was really helpful for both sides, because I think the reality is we can implement a project, but it might not necessarily, we might not get the buy-in, but bringing all these great minds from the facilities, actually, we were able to, make them identify their own risk. Because if there's a complaint, which is part of my role as well in the past, but they deal with it. It's not necessary. We cannot, as a DHP, say, oh, we're dealing with it because we're involved in the service. They would be the people trying to resolve the issue. So Yeah, so they did also in that, it's just quite short time, but I did with the facility did send out a letter to families and next of kin and EPOAs before starting the service. And then a survey was sent out, I think 6 months down the track, or they always discuss it in the resident or family meeting. And there's been no issues. The general comment was that we didn't feel anything changed.
Yep. Oh, that's good. Cassandra Biggs, she's made the comment that some New South Wales health districts have this type of service to support early career nurses who are working in isolation. So I think that that's the aspect of supporting the nursing workforce that you've related to. Malia Macadam said, thank you. Sharon Drescher said, sorry she had to leave, but your model makes great sense. So I think there's a fair bit of accolade there.
Yeah. Aloha, thank you so much for your presentation. Absolutely fantastic service that you responded so quickly in a time of need. And obviously you've been able to continue that. I was curious about the nurses who were providing the service. You obviously had to create the roles quickly, but have you got some professional development ongoing that would be suitable so that you can recruit those nurses, like similar to Noel's presentation about the succession planning?
Yeah, well, I think that's one aspect that we would be in the recommendations, because it's a very small team. The big work was done in the initial phase, wherein we've got this most of our VRNs were VRNs who had experience in aged care, but were mostly already working in the acute setting. So the knowledge gap for them was that, if you're an ICU nurse and you've got someone deteriorating, despite them being end of life, you'd still ask for vital signs. So those were in the initial phase the challenge. But in terms of professional development, I think what we just did initially was then, the same education as we did for the team lead HAs, so that they would have that common language. But certainly I would say that's one of the would be in the recommendations, as to really asking the VRNs as to what they would have wanted more in terms of professional development, because they were half and half. They were still working acutely, so they were still linked to the professional develop unit of the DHB at that time.
I also had a question, Aloha, about, because there's experience in projects and Commonwealth government or state government funding. They so often fund great projects, but then they don't refund. So I'm just wondering what the chances are for this service to become an ongoing service or expanded service. Is that on the cards?
Yeah, so actually, I'm really lucky. We've got there's a restructure here in the health system in New Zealand. So, but the Aging Well regional manager is really interested in continuing it, but in a bigger scale. And we've got I had the numbers, but so we've divided the North Island into 2 regions. I may be wrong, but we belong to the Timanawataki region. So if you remember the map, the 5 regions beside us would be included in our region. And so we're talking about being able to offer it to the rural facilities outside of Waikato. And like I say earlier, not just providing support to those who don't have RN on site at night, but also those internationally qualified nurses who just started working in the aged care sector. So definitely looking into expanding it, and hopefully they can fund it again. But because of the good results that we had, so it's positive, the results.
Very
positive. Yeah.
Well done. It sounds fabulous. So that's all of the questions I can see there. So I'll pass back over to you, Victoria, I think.
Okay, thank you, Christine. I was also wondering if participants listening to Aloha's presentation might like to make some comments about whether this might help us address the problem we're facing with the 24/7 RNs in Australia. Some organizations have been given longer time to recruit those RNs, but I'm wondering if a model like Aloha's would actually fill a gap. So Aloha, do you have 24/7 registered nurses in New Zealand?
Yes, that's a part of the ARC agreement. So age-related residential care facilities. So the requirement is a registered nurse should be on site, particularly for hospital level of care in psychogeriatric. Dementia and rest home, they don't have to have an RN on site, but because most facilities would have the 3 levels of care in one facility. So yes, that's a requirement here.
And my understanding, and maybe somebody here can correct me if that's wrong, but that our government they're not going to allow telehealth to replace that requirement, but they will factor it in as being a support service. But it does seem to me that it could be used in the way that you've been using it there to really help these rural sites who are struggling to meet the requirements. But I don't know, Victoria, is that correct?
Yeah, no, that would just interested to hear the opinions and views of our participants, attendees today as well.